All right, good afternoon, everyone, and welcome to today's session where we'll explore how to leverage SRTR data to monitor transplant program performance. My name is Deanna Fenton, Senior Manager of Educational Program Development and Operations here at the Alliance, and I'd like to thank you all for joining us for today's very important conversation. Now, for those of you who may be joining us for the very first time today, we'd like to request that you take note of the chat feature that's located in the navigation bar at the bottom of your Zoom window. If you have any questions or comments that you'd like to add to the discussion, please feel free to submit them at any time through that chat feature. Now, as a friendly reminder, there'll be no continuing education credits offered for today's program, but we do encourage you to obtain a certificate of attendance as it will allow you a fantastic opportunity to provide us with your valuable feedback. An email with detailed instructions on how to do so will be sent to all of you following the conclusion of today's discussion. As always, today's session will be recorded and made available on demand for your convenience. The direct link and PowerPoint handout will be provided via email following the conclusion of the program, but you can also find that information on our website at organdonationalliance.org. Lastly, for anyone joining us today as a group, we'd like to ask that you take note of the following poll and complete the poll to indicate approximately how many people have joined your group. Now with that, I'd like to go ahead and begin today's program by welcoming our moderator, Katie McKee, Director of Hospital Services and Donor Family Aftercare at LifeSource. Katie, thank you so much for joining us today. At this point, I'll turn it over to you to go ahead and get us started.
Thank you so much, Deanna, and it is a pleasure and most specifically an honor to introduce today's speaker, Dr. John Snyder. John is Director of Transplant Epidemiology for the Chronic Disease Research Group of Hennepin Healthcare Research Institute in Minneapolis. John operates the Scientific Registry of Transplant Recipients, SRTR, serves as Treasurer of the Board of Directors for the Alliance, serves on the Board of Directors for Donate Life America and for the Clinical Policy Board at LifeSource. John also serves in several statistical and associate editor roles for leading transplantation journals. John's many awards include the Executive Director's Award from the Association of Organ Procurement Organizations in 2014. Today, John will walk us through key performance metrics for transplant programs, including the new metrics that will be used by the MPSC to monitor program performance. John will outline how to find and interpret the risk adjustment models associated with these metrics as well. John has created a pyramid he calls the hierarchy of metric needs, and his content today will be in the context of working up that pyramid with the goal of translating metrics into understanding, inference, and ultimately action towards specific goals. I have the privilege of serving on one of SRTR's many perspective gathering councils, and I continue to be inspired by John and his team's thoughtful, holistic approach to incorporating many voices in the community, working toward translating data into meaningful, actionable information to benefit patients. There is a wonderful Alliance spotlight on John written by Jan Gleason, and this is available on the Alliance website. I encourage you to check it out and learn more about John as outdoor enthusiast and avid musician, John's wonderful family, his light bulb moment in statistics class, which inspired his leadership in healthcare, and his epidemiologist mission. John, thank you for the many ways that you lead in the community of donation and transplantation. We are really looking forward to your session this afternoon. Thank you.
Well, thank you so much, Katie, for that very generous introduction, and my special thanks to the Alliance as well for the opportunity to be with you today. The Alliance is a fantastic organization that I'm always amazed by their ability to put out such wonderful educational material and bring our community together. Those of us who work in this field know that there are many players and it's a complex field of organ donation and transplantation, and how do we bring people together to try to advance this field as a holistic team? And I'm so proud of what the Alliance does, and really honored to just share some insights with you today about these new metrics that the MPSC will be using to evaluate transplant performance. as Katie said, she mentioned my mission, my personal mission, and I've always felt just compelled to be able to share information with healthcare providers in a way that is actionable and in a way that is meaningful and in a way that drives, hopefully, eventually to better patient outcomes for the patients we serve. And I think that's at the heart of what the NPSC is trying to do with these new transplant program performance metrics. So hopefully by the end of this conversation today, you will have a better sense of those metrics and some of the tools that we can make available to you to monitor those metrics. Katie mentioned many of my external involvements here shown on this slide by way of disclosures. Particularly the top one here, I do obviously operate the SRTR, but the views expressed today do not necessarily reflect those of the U.S. Department of Health and Human Services, et cetera. So I'd like to make sure that you make that disclosure as well. So without further ado, these are the goals that we are trying to accomplish today. I'll describe the breadth of data that the SRTR provides to transplant programs, particularly in light of the Membership and Professional Standards Committee's use of these data elements. And then just how to interpret the risk adjustment models that go behind these metrics. I think it's so critical to understand that all of these evaluations, we're trying to compare apples to apples across transplant programs. And so how do we do that? So Katie mentioned my hierarchy of metric needs. It's a bit tongue-in-cheek. It harkens back to Maslow's hierarchy of needs. And just so the base of my pyramid here is information. And what I mean by that is there's some information that we as transplant professionals want to know. And what's our next step there? And that is to come up with some data that describes that information. Like if we can write down some observations, write down some numbers, give us something to analyze. From those, I would say those are our basic needs. We have to start there. We have to have some data set available to us. And from those, we can construct metrics. And metrics can describe so many components of our complex system. And you'll notice here, this is really the title of my talk, that knowing is only half the battle. Once you're to a metric, you're only halfway up this pyramid. And so that's why we have this dashed line here where I'm kind of coming at this today, assuming that we are here. And where do we go from here? Well, I think to really get to that next level of what we're all trying to do is we need to be able to understand those metrics so that we can draw some insight from them. And I call that our psychological component or intellectual component of this process, is translating those metrics into that aha moment. Maybe you're a transplant quality professional at a program. What do I do with these numbers? How do I first understand what they mean? And what are they telling me? That's the key question I always ask myself, because if you can understand that, you can probably take some action. And importantly, that action will be guided action. It will be well-intentioned and well-directed action, not just shots in the dark, if you will. That is the goal behind all of that insight, is taking the right actions. And if you are doing this really well, I think that is targeted toward achieving some goal. And that is the top of our pyramid. We're trying to reach that self-fulfillment as transplant quality professionals to achieve a goal, whether that's achieve better outcomes for my patients post-transplant, achieve a better experience for them while they're on the waiting list, get their transplant faster. How do we define those goals? How do we measure those goals? What can we do? So again, metrics are halfway up this pyramid. That is sort of knowing is half that battle. So let's jump in. We're specifically talking today about the Membership and Professional Standards Committee within the OBTN-UNOS framework. They did pass a new policy at the December 6th, 2021 Board of Directors meeting to enhance the transplant program performance monitoring system. That was actually the name of their proposal. I have a screenshot of their website here where you can find more information about the proposal specifically. There are a number of educational webinars there. So for some of the stuff you'll see today, some of that harkens back to some of those webinars as well. But just want to give you a bit of the history here. I always think it's important to understand where we've been, where are we going, right? First-year patient and graft survival have been the primary metric to monitor transplant program performance way back to 1987. That has been the standard metric, but many have criticized this overemphasis on early post-transplant outcomes as quote unquote the wrong metric, that we should move beyond that. In 2019, OPTN, in response to those criticisms, formed what they referred to as their ad hoc systems performance committee. And that committee took a broad approach to thinking about system metrics or institutional metrics. Some might say call that individual member metrics, whether that's an OPO or a transplant program. They sort of took a step back and took a holistic approach to looking at this. And they recommended to the OPTN board of directors that this holistic approach should be pursued, that it should incorporate a broader look at hospital performance and or OPO performance. This concept of a balanced scorecard came up quite a bit. But the general idea there is that we should be looking at a multitude of metrics to describe quality. Quality is not just first-year graft and patient survival. So in 2020, the MPSC formed what they referred to as the Performance Monitoring Enhancement Subcommittee in response to that board of directors recommendation. And of course, the SRTR supports the MPSC, so we've worked closely with them in these debates. And again, they put a proposal forward to the OPTN board, which passed in December of 2021. I think it's useful to step back again and think about what's the order of operations here. And the reason I think this is important is, again, thinking back to our pyramid, it helps, I think, to think about the goal at the top of the pyramid. And then you can think about, is this the right metric to achieve that goal? And important, and I'm going to touch on some more of this before we get to the specific metrics, who is looking at the metric and why? We cannot judge a metric as good or bad for a stated purpose unless we really define what that purpose is. And even more broadly, who is the person that's looking at this? Who is the decision maker? Who's trying to gain insight from that metric and why? I often hear criticisms of metrics, but I think at the heart of it, it's a criticism of the wrong person looking at the metric or for the wrong purpose. So I tend to approach this as there aren't good and bad metrics. There are good and bad uses of metrics, okay? So we have to really think about that, and I'll show you a bit about what I mean. So once we've defined in step one the goals of the metric and who's looking, then that really helps us narrow down what are the best metrics we can come up with to meet that goal or the set of goals. And then finally, there's this concept of screening tests. And it's a bit of a broad concept, but in the context of the MPSC, we often hear this referred to as a flagging rule. In other words, the MPSC looks at, say, first-year graft survival. What is the rule they use to decide if you pass or fail? Okay. I'm going to refer to that generally as a flagging rule. Some call them an identification rule. Whatever the concept is, the idea is that you define a standard. And the program either meets the standard or they don't meet the standard. We can define these in terms of a medical test. What are the predicted false positive rates? What are the predicted true positive rates, et cetera? The reason I think that's important, and I'll show you the screening rules that the MPSC is putting forward for this new set of metrics. I often hear people say, this is a bad metric because too many programs are flagged, okay? In my opinion, that conflates two different issues. A metric is a separate and distinct thing from the screening rule. So we can look at first-year graft and patient survival, and we can rank programs sort of top to bottom and how they perform on that metric without ever describing a screening rule. And I think first-year graft and patient survival, maybe it's not the best metric to look at for a stated purpose, but it is a metric that we can look at. But the screening rule is a separate decision that is made by, in this case, the MPSC, and it has to meet the goals of what they're trying to achieve. They can decide where to set that boundary, how high to set the bar, how low to set the bar. It's really a separate problem. And so I always encourage people to be clear. If you don't like a particular metric, are you not liking the metric itself as perhaps measuring something that's not important or not the right thing? Or are you criticizing the screening rule as being an inappropriate screening rule? It's important to separate those out in your mind. So if we step back to who is looking at the metric and why, I've just listed 4 potential examples here of people that look at metrics. Programs might have quality professionals that are trying to decide how to improve processes to improve patient outcomes. Patients may be looking at metrics to decide where to seek care. Insurers might be looking at metrics to decide which programs meet their qualifications for programs of excellence. And then, importantly at the bottom here, today's topic is the MPSC, which is trying to decide which programs should be reviewed for safety or performance improvement that the MPSC could get involved with. So each of these are distinct goals. The reason this is important is that this is a complex system, as we all know, right? So transplantation involves many players. We all know this very well, those of us on this webinar. Many different organizations and institutions are involved in the process of transplantation. And this is all overseen by the federal regulation that's codified in the OPTN final rule. So there are so many complex players, both at the institutional level as well as the federal regulations and policy level that oversees all of this. So this is a diagram that we had looked at with the MPSC to try to make sense of all the players involved and the different types of metrics we could look at. So I'll spend just a moment here just describing this figure. In the green columns, we sort of have the process of transplantation from left to right. Pre-listing, what happens to patients before they're even placed on the OPTN waiting lists. Then we have the wait list period. I have an OPO labeled there, sort of things that are happening at the donor side, the deceased donor side of the process. We have the offer process once offers are being made to candidates. And then we can separate perhaps the post-transplant outcomes into early and late post-transplant periods. And then horizontally at the top here, I have in the purple box labeled what I consider to be system performance measures. And these are metrics that we could define within these various domains that touch across multiple players and multiple aspects of the process. And that's why I feel that these metrics, while they exist or they could exist, they describe if the system as a whole is performing better or worse on that particular metric. But because the metrics cross multiple domains of the process, that is why I feel like those are, in my opinion, team player metrics, right? They're not necessarily describing transplant program quality. They're not necessarily describing OPO quality. It's the team component of trying to make the system better. Whereas at the bottom, we can define some metrics that are more directly within a specific domain for specific institutions like transplant programs or OPOs that have more direct control over. So when the MPSC first started evaluating metrics, they looked at this example here. This overall survival from listing, I think, is a fantastic measure for a patient to look at when they're considering listing at a particular transplant program. Patients often say, well, I want to know if I list here, what's my long-term survival going to be, whether I get transplanted or not. And that crosses multiple domains of the process and multiple players are involved. The arrows pointing up to that metric from below are meant to say that if you improve these metrics below, the patient's overall experience will probably improve as well. So if you improve their waitlist mortality rate, you keep them healthy so they can stay active on the list. If the OPO in the area has really good donor conversion, if the program is good at accepting the offers that are coming their way, and they have good patient and graft survival at the end here, and perhaps reduce rejection episodes, et cetera, all of that plays into having the patients have a good experience, a good overall survival from listing. And it's for that reason that the MPSC chose to look more toward those metrics at the bottom. If they're trying to help OPOs or transplant programs improve, they want to focus on that part of the process that they have the most control over. So they greatly focused their attention below, and they chose these 4 in red to look at for that more balanced scorecard approach for transplant programs. Importantly, these are all rate ratios, which I'll talk more about. That means that we're comparing observed outcomes to expected outcomes based on risk adjustment. So we're going to take a look at each of those one by one. MPSC felt that these were good because they measured aspects of care that are clearly within the authority of the OPTN. They measure aspects of care that the transplant program can impact, and it has a clear desired good direction, okay, or clear desired outcome, if you will. So let's take a look at each one in turn. There are 2 pre-transplant metrics and 2 post-transplant metrics. The pre-transplant metrics are waitlist mortality rate, offer acceptance rate, 90-day graft failure rate, conditional 1-year graft failure rate. We'll take a look at each one in turn. And again, they're all rate ratios comparing observed to expected. So we'll start with the pre-transplant or waitlist mortality rate ratio. I always ask the question, what is this in English? Can I write down what this metric is trying to do? I think that's important, right? Any good metric, we should be able to describe in English, not math, what we're actually trying to measure here. So the question that's being addressed by this is, on days when a patient is not transplanted, are patients listed by this program more or less likely to die compared with similar patients nationally? And there's a couple key components to this. That first phrase, on days when a patient is not transplanted. So what's really being measured here is, if you consider your dialysis patient per se that's on your wait list, are your dialysis patients on a day you can't transplant them, is their mortality experience the same or higher or lower than other dialysis patients on the list at other programs with similar characteristics? It's important to know that this is measuring on days that the patient is not transplanted. So this is what we call in statistics a transplant censored metric. So it's not the case that transplanting your patient faster, accepting organs faster, that's a good way to lower deaths on your wait list. But the nuance here is subtle, but it's important. This is actually asking, on a day that I can't transplant my patient, for whatever reason that is my patient more or less likely to die? So if the program is looking to intervene on this metric, they're looking at actually the care of those patients on a day that we assume this patient is not going to be transplanted. So it's a subtle distinction, but I think it's an important one for understanding really what this is measuring. As I said, these are all rate ratios. And so you'll see 4 slides in my presentation that look essentially like this. We're essentially defining what we call O and E. O means how many observed deaths, or in other metrics, we'll look at our other types of events. How many observed deaths between listing and transplant do we find? And then how many expected deaths were we expecting to see for these types of patients between listing and transplant? We can convert those O's and E's into a waitlist mortality rate ratio. This methodology here, this is the only math in the entire presentation, I promise you. If you simply add 2 to the observed count and then divide that to the expected count plus 2, you arrive at the waitlist mortality rate ratio. And that plus 2 is, there's some complex math behind that. This has to do, maybe you've heard the term, the SRTR's Bayesian methodology that applies what we call in statistics a shrinkage parameter to these estimates. That's exactly what the plus 2 is doing. There's some complex math behind that, and we do have a paper in the AJT if you want more detail about how that plus 2 works. So in our reports on the SRTR website, here's an example kidney program. We present that rate ratio on the left just as a blue dot with a confidence band around it. So in this case, a 1.05. Rate ratios, remember, we're dividing observed by expected. No, I'm ignoring the add 2 there, but you get the idea. If it's 1.0, that means the observed was essentially exactly the same as the expected. So a 1.0 would be that your performance is right at what we would expect for your waitlist mortality experience. Higher than 1 would be higher mortality experience than we would expect. And lower than 1 would be a better survival rate than we expect for your waitlisted patients. And then that on the right, the blue dot is the particular program being evaluated. And we can compare that to how you sit with your peers. We stratify that from left to right by how many person years we've observed on your waitlist. So that's essentially the volume of your waitlist. How big is your waitlist? So you can kind of see how you fall relative to your peers. This program at 1.05 is essentially right at national average. You can see the confidence band there, and they sit right in the middle of those dots there on the right. We do make tools available. I won't get into depth on these, but we do have webinars on our website available to learn more about these. There are workbooks available on the SRTR secure site so that you can do your own subgroup analyses for patients in your waitlist mortality rate experience. So the example shown to the right, we show the overall for all candidates, but then again, stratified by certain age groups. And there are some pre-canned substratifications on those tools, but you can construct your own as well. So those tools they're in Excel files, and so you have to have a bit of skill with Excel. But again, we have some tutorials on our website about how to use those if that's helpful to you. I think it's important to drill in. If you see an elevated mortality experience, the first question is, what types of patients is that occurring in? Can I narrow that down? And that would help me target those interventions. So we talked about a screening rule earlier. MPSC did define screening rules. They have to decide which programs are they going to interact with, or which programs will they give a pass to. The way they describe these is based on how certain they are of the evaluation and how far of an outlier is this program's evaluation. So in this example, in the middle sentence, the MPSC will get involved with the program if there's at least a 50% probability that the program's waitlist mortality rate ratio is greater than 1.75. In other words, we're more than a coin flip certain that this program's mortality rate is 75% higher than expected. Remember, a hazard ratio or a mortality rate ratio of 1.75 means that your patients appear to be dying at a rate that's 75% higher than what we would predict for other patients, similar patients nationally. And so that is the level, the extreme outlier level that the MPSC would like to review and see if there's a way they can help intervene on that outcome. You can visualize what this looks like. Each of the dots on this plot represent a program evaluation. On the y-axis, vertically, we start at 1.0. So these are all programs. 1.0 would be that their waitlist mortality experience is exactly what we would expect. So just to zoom in on the quote unquote bad direction of this evaluation, each of the dots here have waitlist mortality rates greater than 1. So I've essentially cut off the bottom of this graph. There are as many dots below that line as there are above 1. But just for zooming in on the direction the MPSC is hoping to look at, the purple zone there are those extreme outlier programs that would come under review under this criterion for the MPSC. Some common questions come up. I thought I would just address a few of these as we go through. Does monitoring waitlist mortality disincentivize listing of risky patients? This is a common criticism essentially of any metric we look at. You could apply that same question to post-transplant outcomes. If you monitor my post-transplant outcomes, I am going to deviate away from the risky transplants and only do the easy ones. In other words, I'll deny access. And you can apply that same concept to pretty much any metric you could think of, which is exactly why the SRTR does risk adjustment. We do not want the metrics, the evaluations, to disincentivize those types of transplants. We're comparing observed deaths to expected. Remember, if you're a transplant program who takes on risk and does riskier donors and does riskier transplants, to the extent that we're able to define that in the data that we have, we're comparing those same types of patients with those donors to the same types of experiences elsewhere. Now here we're talking specifically about waitlist mortality, so that donor side of the equation is not there, but the same concept applies. We do adjust these models, and I've listed out here what's currently included in, for example, the kidney waitlist mortality model. So there's many things that go into that calculation. And this gives me the opportunity to point out on our website where you can find this information. So if you go to the SRTR website at srtr.org and you look under the tools menu, you will see the risk adjustment models are the first thing that pops up. And again, you've got different categories of models that we can look at. You're going to look in the waiting list section there for the current wait list models. And it will give you a tool that looks like this. You just choose your organ, and for this mortality rate experience, we want to choose that pre-transplant mortality rate outcome in the middle. And then we do have separate models for adult and pediatric candidates on the wait list. So you would just choose which model you're interested in there. And that will bring up a tool that tells you everything that we adjust for and where it's generally located within the UNet system at UNOS. And a lot of information about these coefficients. You can actually, if you have a statistician on staff or you are one yourself, you can download the model itself and play with it and get to know it. But importantly, I think there's a tab that allows you to visualize the effect of each thing that we adjust for. And I'm showing you an example here of candidate age at listing. And this is meant to show you how the SRTR takes into account the risk for these different types of patients in your population. What the blue line is describing is how the model expects the waitlist mortality rate to grow as patients age. And so, for example, let's say you list a 65-year-old patient relative to a 25-year-old patient on your list. If you locate where those two ages are on this figure, and you look where the blue line is, you can see that the blue line at age 65, if you just take the ratio of where that is on the y-axis to where it is for the 25-year-old, there's a 2.3-fold higher risk for the 65-year-old than there is for the 25-year-old to die on a day they're not transplanted, simply because they're older age, right? And so I've heard programs say, well, I don't want to list any, older people on my list. And I point them to this graph and say, we are expecting, this is based on national experience for these ages. We don't draw these lines from scratch. We actually develop them based on what's actually happening nationally for the cohort that's being evaluated. And so this is real data. The model expects that for your 65-year-old, their chance of death is 2.3 times higher than the 25-year-old on your list. And so simply limiting your list to certain age groups will not have the intended effect unless it really is indeed in your older patients where you're experiencing elevated mortality. So that's why I say it's important to dig into your data and see, maybe it's the young people on your list that have elevated death rates. Is there something we can learn from that? So it's important to understand how that risk adjustment works. So a lot of information there. I can go through the others in a similar fashion. They all have sort of this similar construct to them. When we look at offer acceptance rates, the question being addressed here is, given the types of offers received to the specific candidate, does this program accept offers at a rate that's higher or lower than national experience for similar offers to similar candidates? Again, this is constructed in the same manner. So you'll see the same math here. We're taking a look at how many acceptances did the program have for the offers that came to them, and how does that compare to what we would expect them to have accepted based on what other transplant programs are doing for similar offers from similar donors to similar candidates, okay? All of those similar phrases are really important in understanding this metric. So here's another example of a program's offer acceptance ratio. This one here, their overall offer acceptance is at 0.53. So that is about half what we would expect. So this is a low accepting program relative to what other programs are accepting for similar offers. And so that's perhaps interesting. The SRTR website does also provide breakdowns. And first, you can look at it overall. So we show you for your program, what were the total number of offers you received in this 1 year period? How many did you accept? In this case, on 104 on that second row under the program column. But the model predicted for the types of offers you received to the types of candidates they went to, that if you would accept those at the rate that other programs accept them, you would have taken 198 of them rather than 104. That gives us the acceptance ratio of about half, and the credible interval is shown there. We do also provide, depending on the organ, different subgroups of types of offers for you to look at. This is a kidney example. So we're showing you, if you stratified your offers based on the donor's risk as measured by the KDRI, the Kidney Donor Risk Index, for low, medium, and high KDRI, what are the acceptance rates? So this, you can see that this program tends to accept the low risk donors at a rate that's a little closer to national average at 0.83. But then for both the medium and high risk donors, they're slightly lower than half what other programs are accepting. And then over there to the right, we have for offers that are hard to place, we call these, and these are defined differently for different organs. So this is saying if you got an offer that was already declined by 100 other candidates on the list, what is your likelihood of accepting those? And this program very rarely accepts those at a 92% lower rate than expected. That's the 0.08 there. So very low acceptor of those offers that have already been declined by other programs. The SRTR on the secure site for programs does have Cusum charts. These are quality control charts. We have these available for post-transplant outcomes as well. This is for offer acceptance. And so you can see for this program, there was a period of time from left to right. The squiggly purple line here is saying, we're observing every day your offer acceptance practices. And if it's trending low, that line will raise up. Okay. And so you can see in June here of this period of time, in June of 2021 at this program, their offer acceptance patterns dropped off, and that made this line rise up. And then we have a signal threshold where if it hits that red line, we have enough statistical evidence to say that something actually changed in the process of this program during that period of time, sufficient for this chart to pick up that something anomalous is happening. So if you're looking at your offer acceptance practices and you see this chart start to deviate like that, that is saying that we're able to pick up a signal that your offer acceptance practice has changed for that period of time. On the secure site, we also have this table to the right, which also describes your offer acceptance patterns within various subgroups. Again, we have stratified by KDRI, but then we offer a couple additional categories here for your DCD donor offers or PHS increased infectious risk donors, Hep C positive donors. And interestingly, we have a weekday versus weekend assessment. So it's been demonstrated that sometimes at transplant programs, the weekend acceptance of offers can trail off. And that's what that weekend is trying to measure there. Again, the MPSC designed a screening rule, and I'll just jump to the visual of this so you can see how it works. The MPSC is trying to look at the outliers here, and they define that as having an offer acceptance ratio that's at least 70% lower than expected. And you can see of all the dots here at all these different programs, those ones in the purple zone would be the ones that the MPSC would engage with to see if we can improve that offer acceptance practice at that program. Again, the risk adjustment models for all of this they're complex for offer acceptance. There's a lot of things that go into these models. You can find them again at the same spot on our website if you look at the offer acceptance tool there. This is just what it looks like for each organ. We often build separate stratifications within certain types of offers. To the right there, this is the kidney choices. And so you can look at how we take within each of those strata of KDRI, we build separate models, and there's lots of elements that go into these. One of the common questions we get about this is, well, I could improve my offer acceptance by filtering offers, so it allows you the ability to say, I don't want to see certain types of offers. And the question we get is that ultimately will harm my candidates because I'm going to filter out offers for them. And I think that's a perception that limiting offers to those a program will accept will improve the offer acceptance ratio while ultimately harming the patient by limiting their access to transplant. This is something the MPSC and the committee considered seriously. I think there's important things to think about when you think about this. One, offer acceptance rate ratios are adjusted for many donor and candidate factors. We also adjust for logistical issues. We know what the offer number is, so we're adjusting for that in the process. We know if 100 people have already turned it down. We also adjust for the distance that donor is from your recipient. So I've heard programs say, well, I entertain a lot of offers from far away, so that's going to hurt me. Well, we take into account how far away that offer is from your recipient. Secondly, offers that your program is very likely to accept are also offers all programs are very likely to accept. So filtering offers down to those sort of softball offers, if you will, can raise a poor offer acceptance evaluation to average, but it's not necessarily going to make you look better than average. And the MPSC felt that if that's actually true, that we can encourage programs to filter out offers that they are very unlikely to take, that ultimately that has the potential to speed up the allocation process and thereby benefiting all patients, and still having your particular candidate in a situation where Those offers you're screening were not offers you were likely to accept at all. So it probably won't impact that patient's ability to be transplanted. I thought it was worth touching on one other FAQ we get about the offer acceptance evaluations, that this benefits large programs. Large programs have larger lists, more candidates. They might be more likely to accept an offer. It's important to remember that we're evaluating at the candidate level here, or the offer level. So we're not asking the question, did you take the organ for any candidate on your list? We're asking the question, did you take the offer for this specific candidate on your list? And if we look at the data, this is stratified by the number of offers program receives here from left to right, so small to large programs. And then on the y-axis here is the offer acceptance ratio. This is for kidney programs. And you can see there's actually a slight downward trend. So what that means is that it tends to be the opposite of what people think, that larger programs tend to systematically have slightly worse offer acceptance ratios. And in my head, there's a chicken and egg problem here, because maybe their lists are very large because they are not accepting offers at the rate that their peers are. But certainly it doesn't trend in the direction that most people would assume, that large programs are going to have an easier time looking good on this metric simply because they are large. This plays out in liver as well. It's actually slightly more pronounced in liver programs. Liver programs with larger lists tend to have worse offer acceptance practices than those with smaller lists on average. So that summarizes the point I was just making, that it's perhaps counterintuitive that would somehow benefit large programs. It tends to actually play out to be the opposite in practice. So I think we're mostly familiar with the post-transplant outcomes monitoring. So I'll just wrap up by sort of a combined look at the new post-transplant outcomes. The MPSC made a couple changes to monitoring the traditional one-year graft and patient survival. First, they split this into two different distinct time periods. One is the first 3 months, first 90 days, if you will, post-transplant. They want to monitor that separately from what we are calling conditional 1 year. So what does conditional 1 year mean? Conditional means we're going to look at all patients that have at least survived those first 90 days with graft function. And then we're going to look at what happens to them the rest of that first year. So we're calling that conditional first year survival. Conditional means we're conditioning on the patient being alive with graft function on day 90. The second big change that the MPC is going with here is they decided to eliminate looking at both graft and patient survival. Historically, they have looked at both. The two outcomes are very highly correlated, particularly in the non-renal organs. And so the MPSC felt that simply monitoring graft survival looks at that combined endpoint of death with function or graft loss. And so they felt that that was the best use of their resources to really help programs look at that combined endpoint. We have more events there. We have more power for the MPSC to have more precise estimates for that outcome. And given that they are very highly correlated with patient survival, they felt it was they would simplify the process, if you will, if they just looked at allograft survival. So what question is being addressed here? Given the types of recipients and the types of donors transplanted, is the failure rate at this program higher or lower than expected based on similar transplants nationally? Again, this is constructed in this O to E framework. We're looking at observed graft failures either within 90 days or within that conditional 1 year survival period, and comparing to that to what we would expect from our models. This is a sense of what this will look like on the SRTR site. This is an example of the first year post-transplant outcome that's currently provided. SRTR is working to provide the 90-day outcome and the conditional 1 year similarly on this plot. Just be in the drop down to the left of the time frame. The program would be able to choose 90-day or conditional 1 year and get these similar plots. So you can see what your evaluation is, and then at the bottom, how you stand in relation to your peers. In this example, this program's had first year graft failure rate was 0.62 hazard ratio. And so that would say, you look at the difference between that and 1. Remember, 1 would be national average. So this one is 38% lower. So 1 minus 0.62 is 38.38, 38% lower. And you can see that reflected below in the plot where they are on the better side of the equation for post-transplant failure rates. Again, the MPSC developed a screening rule here. This looks exactly the same as what we saw earlier for the waitlist mortality. That is the purple shaded region. They are going to look at programs with evidence, at least 50% probability that their failure rate is at least 75% higher than expected. So the outlier programs in the purple zone there are the ones that would fall under MPSC review to see if their outcomes could be improved. I think one observation I would make here is they did raise this boundary a bit. So there are fewer programs being screened for post-transplant outcomes here than there were historically. Even though the boundary is at 1.75, we have that 50% certainty rule, right? We have to be at least 50% certain that they're that high or worse. And therefore you can see most of these dots in the purple zone, if you compare to those to where they are on that y-axis, they tend to be in the hazard ratio area of 2 or worse, or very close to 2 or worse, meaning that their failure experience is actually double what we would expect. And again, this is the first 90 days. Similar boundary applies for the conditional 1 year. So again, here you can see that the programs that would fall out into that space there. All of the dots on all of these plots I've shown you combined all kidney, heart, liver, and lung programs together on one plot. MPSC felt it was essential to have the same boundaries in effect across all organs. And that was because they wanted to find regions that had clearly some outlier experience represented, regardless of what organ type it was. They wanted to be consistent in the types of outcomes that they were looking for across those different organ types. And as I said, these are higher than the old MPSC boundary. I drew the line here, which is the pre-existing MPSC boundary before this new rule takes effect in July of 2022. And so you can see how MPSC did move the purple zone up higher compared to what it used to be historically. Those models are also available in the same place. Just look for the post-transplant outcomes models. SRTR will be using the first year post-transplant outcomes models to develop the 90-day and conditional 1 year outcomes. So both of those can be derived from that first year outcomes model. And so we also have a 3-year outcomes model. If you look to the bottom right here on my tool, where we say choose a time frame to understand the models used by the MPSC, you'd be looking at the first year outcomes models there. You can choose adult or pediatric and be sure to choose the outcome graft survival. That is the outcome that the MPSC will be looking at. If I have lung highlighted here, if you were looking at kidney or liver, you would have the option to choose between deceased donor and living donor models as well. So we often get this, well, how well does this risk adjustment work? I would never say risk adjustment is perfect, right? It's very difficult to describe the complexity of any patient or any donor based on the data we have. But given what we know, how well does the statistical modeling work? So here's an example about adjustment for KDRI, which is the Kidney Donor Risk Index. And on the left here, we're showing what would happen if we didn't adjust for that in our evaluations. And this is a bit complex, and I have the reference to the paper there if you want to go dig deeper into this. But there are 20 dots on that left panel. And let's assume that those dots, these are real data, but let's assume that what we're looking at here are 20 unique centers. And it just so happens that those centers take on from left, the leftmost dot takes on the least risky donors in all of the country. So that's 5% of the country's donors. They all go to that program and they're the best donors in the country. And then on the other end of the spectrum, that program on the right takes the 5% of the riskiest donors, right? So that program just gets all of the worst donors. Those would be all KDPIs, 95 and above. If we didn't adjust, that program to the right would look like they have failure rates 2.5 times the national average, okay? And sort of the converse of that is true on the left. What's shown on the right is those same evaluations for those 20 programs after we adjust for the KDRI of the donor. And so you can see what happens is the risk adjustment eliminates that relationship. So now the KDRI of the donor is no longer influencing the evaluation systematically. There's no systematic deviation, systematic bias for that based on the KDRI anymore. So you can do a similar plot like this for anything that's in our models. The model exists to eliminate that so that the KDRI is no longer the cause directly of a good or bad evaluation of the program. The MPSC specifically chose boundaries that did not flag a certain number of programs for each metric or a certain percentage. I think grading on a curve is often discussed in the context of what the MPSC is doing. It's important to understand that while people are being judged relative to national experience, which I think is appropriate, it's different than what many people think of as grading on a curve, whereas, say, perhaps in high school, the teacher would assign the lowest 5% of patients, a certain grade, and then the next 10% a certain grade, et cetera. That's not how this works. Essentially, the MPSC defines that clinically significant boundary of performance that they feel is appropriate to review programs. And then however many programs are outside that boundary, they will review. It's not a certain proportion each time. You can see in the first row here for pre-transplant mortality rate ratio, when they were developing these boundaries, there were 0 kidney programs that met that criteria. So the MPSC, it is possible if all programs are performing similarly, that there could be 0 flags for the MPSC across all of these metrics. That is possible. The metrics do grade on a curve in the sense that they are comparing your experience to what other programs nationally are doing, but the MPSC's criteria does not flag, say, the bottom 5% or the bottom 3% of programs. That's not how that works. I hope this was helpful to you. I know I've gone through fairly quickly. We do have some educational webinars available on the SRTR site if you want to take a look at these. Some of them are short, some of them are about an hour long, so we'll go more in depth. And I also remind you that on the OPTN's website for the MPSC, they have webinars as well by Rich Formica and Ian Jameson that give more information about these metrics as well. So again, my goal is that hopefully this was helpful to you and you can have some new insights going into these metrics as they become available through the SRTR and the MPSC going forward. So Katie, I'll go back to you, and I hope this was helpful to our listeners.
John, thank you so much. I knew I would learn a lot, and mission accomplished. Thank you for especially the context in which you set and framed the discussion. And then it was fun to watch your sort of question and answer session there at the end covered a lot of the questions that we see coming through. I will add a couple. There are many questions both submitted prior to your session and during your session that are related to the E in the O to E and the expected ratios. One question in particular that you addressed certainly, but may pose it to you to see if there's anything you'd like to add, is about the any potential discussion by the MPSC or others about expanding the parameters that are included in the expected calculations. So Susan Crespo lists a couple of potentials like coronary artery disease, ejection fraction, and others. Would you like to comment on those conversations?
I think these conversations are extremely important, and this is something we at the SRTR have been trying to do a better job of engaging the community in these efforts. I certainly always welcome suggestions if you think there are things that are missing. We have indeed changed risk adjustment models in the past based on feedback we've received, and that might be complex interactions between variables. For example, we had people say, well, it was one of the OPO yield metrics that the MPSC looks at. They said, well, when you look at DCD donors, you should really look at the DCD downtime in addition to just being a DCD, is how long did it take the patient to expire, and you should look at the interaction with that and then stratify out the brain dead donors. And indeed, our statisticians went to the drawing board and figured out, yep, there is indeed a relationship there that makes our models better, and we implemented that. Numerous examples of that exist. The question is really about what should we be collecting that we aren't now. We depend on our community to help us with that. And there's a balance between how much data are we going to ask centers to collect We are at the SRTR not ignorant of the fact that this takes effort to collect and report these data. But certainly performance evaluation of the nation's transplant system is a key function of the OPTN system. And so I think we should be willing as a community to capture those key components so that we can do the most fair adjustments we can. In response to some of the specifics there mentioned, I know ejection fraction, gosh, I want to say maybe 10 years ago, I know that came up before the Heart Committee and others when there was a previous effort to change some of the data collection. And there was disagreement in the community about whether we were going to ask all programs to report an ejection fraction. And some of the clinicians felt that it wasn't necessarily warranted to measure an ejection fraction on all of our donors or all of our candidates. So it was not put forward as something that would be collected at that time. And certainly coronary artery disease, SRTR is an agreement that we could do a better job capturing things like that. And so we recently also supplied an evaluation to HRSA about some of the ways we believe that the data collection could be improved so that we could do our job better. And so we're happy to hear those suggestions and engage with the community.
Wonderful, thank you. A number of the questions that were submitted in advance, I just want to sort of ask you to validate some of the comments at the end around, as you covered what's available on the SRTR website. There were questions about when it comes to expected any of the ratio inputs, what can transplant programs do more real time to anticipate outcomes that they'll see in 90 days and 3 years, all those things. So let me ask John, at the end of your presentation, when you covered those resources that were available and the data that can be pulled and sort of plotted, could you speak a little bit more about that? And is that the piece that really you would recommend centers look to more follow real time what they can anticipate seeing for their expected information?
Absolutely. Yeah, it's such an important question because I think that back to my pyramid, right? If we can't actually learn from this, what good is it, right? So we've tried to make tools available. We are in discussions of ways to even improve that as we speak. What could we do better? I would say that the two tools, we have Cusum Charts now for monitoring the offer acceptance practices and monitoring post-transplant outcomes in that first year post-transplant. Those are a good start. Those give you the as real time as we can do, sort of daily tracking trends of how your metrics are trending. So I think that gives you some insights. There's actually tied to those Cusum charts a data report that you can pull up as your center and look at all of the data that we have that went into that particular Cusum chart. So you can do your own quality checking of the data elements that go into that modeling, because if they're not accurate, that's an opportunity for you as a program to correct those fields within the UNET system. So the SRTR has the best data available regarding your patients and the donors. Secondarily, in addition to those Cusums, we have what we call our expected survival workbooks. These are the Excel files I showed you that will contain all of the patients in your current evaluation, and it shows you the exact calculation for each patient. Now, these can be complex workbooks. I don't discount that. But I think that, with a little work, you can understand how they're built and how you can work with them. They allow you to turn patients on and off in the evaluation. So for example, you could say, well, how do my brain dead donor outcomes compare to my deceased donor, my DCD outcomes in my transplant recipients? And so you could do those subgroup analyses and see, if I do have a elevated failure rate, can I narrow down where that's coming from? Importantly, and I think some people don't recognize this, you can subset those outcomes in those tools based on things that we know, right? So we do know DCD status or DVD status. We know the candidate's age, for example. There are many things that we know that are shown in those Excel files, but you can also subset it by things that you know that we don't, right? So the patient IDs are there, so you can line up these patients with your patients in your clinical records. And so, for example, I've seen programs do things like, well, I want to compare outcomes for different surgical teams or different immunosuppression protocols that we use, or whatever the case is, and you can say, well, okay, I know that these patients were this this category and these patients were this category, so I'm going to compare those there, even though those aren't in the SRTR models. So there are unique things that you can do as a program there. And I think that this knowing is half the battle concept really applies here. Is you need to do a bit of homework, I think, yourselves to dig in and see, can you narrow down some trends? Where do the problems appear to be? Are there systematic changes we can make in response to that? I've heard before programs say, well, I really thought it was my DCD donors, but it turns out their outcomes were great. And it was my DBD donors where we were having problems. And what could we learn there?
John, I think your last comment is a perfect bridge to another category of question around quality of organs accepted, sort of the marginal organ question, and how programs may or may not be disadvantaged. You certainly spoke about this throughout your presentation, but that's sort of a category of question that I might ask if you'd like to speak to any more, that quality of organs question.
Yeah, I mean, in terms of the offer acceptance modeling that we're doing, I encourage you to look at those models. Those are the most complex models we have. And the reason that they can be complex is because we have so much information. When you look at the number of offers, over 1 million kidney offers made in a calendar year, right? So we have a lot of data here. We can evaluate what's happening around the country in great detail. And so we know a lot about the donors themselves. We know about the candidates they're being offered to. I just really want to emphasize that, dig into those models and understand what we're able to adjust for and how that risk adjustment works. Don't assume outright that you are disadvantaged because you're being offered more of these quote unquote risky donors, or you're willing to take those risky donors, therefore your outcomes might look worse. That is not necessarily true. It just depends on how your performance is with those offers and with those recipients that receive those offers compared to what your colleagues are able to achieve nationally. So I guess I encourage people, really try to dig in and understand, and we're always here to help. Just reach out to us at srtr@srtr.org. That's our helpline. We have a team ready and willing to help and help understand that. But I guess I always encourage programs, don't always trust your gut that you need to pull back on risk. It might not be the rational thing to do.
John, thank you. I always think in an ideal world, we would block time after these webinars to follow up on all we've learned. A perfect example of that would be sort of playing around with all the resources available. So thank you for that. I think with that, we are at the top of the hour. And so I would like, John, to thank you again for your not only expertise, but also the time that you so generously give in the community, teaching and really doing so much listening to inform the work that you lead at SRTR and in many other facets of your community involvement.